The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate this month to be joined by Dr. Shawn Mendenhall, a hand surgeon at Primary Children's, primarily at the Lehigh campus, right?
Yeah, actually, I split my time about half and half.
Oh, okay.
Yep, there's Salt Lake campus and then the Lehigh campus.
I still haven't visited. I understand it's a beautiful place.
Oh, it's great. Yeah, and the really cool thing they've done, if you've ever been to any hospital, you know it's this maze, right, of old buildings and new buildings, and it's like how they connect there.
Yeah.
Well, what they did with the Lehigh Primary Children's is they built it with a lot of future growth in mind. So a good amount of the space is actually shelled space for future expansion, which was really cool. It looks a lot bigger, I think, than the Salt Lake Primary Children's Hospital, even though it's currently doesn't have as many functioning beds. But I think it has that potential future, I think, to be even larger as a big hospital there for the southern half of Utah.
Yeah, big need down there. And, of course, the Salt Lake campus has grown and spread and become more buildings, just like you described. Well, we were fortunate this month to be talking about the surgical approach to spasticity, mostly of the upper extremity. We talked last week a little bit about the history and the rationale, the basis for what we're talking about. This week, we want to talk a little bit more about the individualized surgical planning, how each case is evaluated. Before we start, would you like to mention your conflicts of interest?
Yeah, so I'm a consultant for a company called Polynova that makes an artificial skin, which is totally unrelated to what we're talking about today.
Okay. So let's dive right in. How do you evaluate a patient's needs and potential for surgery?
Well, so this starts out with just a simple office visit with myself, and we do a battery of tests on these patients with spasticity. So we evaluate what extremities are affected. This can be somebody with hemiplegia that has one side of their whole body affected, or it could be spastic diplegia, both lower extremities affected only with fairly normal upper extremities, or some combination of any of the above. And so we start out by looking at where extremities are affected, and then we'll measure the range of motion. We'll try to get an idea of their baseline function, by how much volitional control they have of these muscles that are tight. And then we do oftentimes just a very simple test called the modified Ashworth score. And that's where we yank on their extremities and see where that tightness catches and then how much of the full range we can get out of it. And that gives us just a baseline understanding of where we're at and how much intervention is needed. We also have our patients see for the upper extremities, our hand occupational therapist at the same time to do another full battery of tests. And if they have lower extremity spasticity, then we have seen some of the physical therapists as well to test some of these things in a little bit more detail. And what that does, that gives us a really good baseline set of measurements. And then what we can do is after we do different surgical or even medical interventions, then we can track our progress with their function throughout time. So typically we have that standard battery test before, and then at every of their subsequent visits after interventions, we do the same tests and so we can see where we're at.
In general, you always start with some sort of team approach.
Absolutely. Yeah. And some of it also depends on how medically optimized these patients are, right? Because before we even think about any of the surgical options, we need to make sure that just some of the basic medical options have been optimized. And that could be things like oral anti-spasm drugs like baclofen, for example, just to help relax the muscles. Many of these patients undergo Botox injections for years before they come to see us. And so Botox injections, for example, can be done every 4 or 6 months on the tightest of the muscles to help relax them. The downside with that is it's a little bit of a painful procedure, right? And often requires some sedation. And so parents and patients often get fed up with doing these over and over. And again, that's when it's probably time to start thinking about something more permanent, like some of the surgical options we talked about last time.
You talked a little bit last time about the selective neurectomies. Do you sometimes use Botox to evaluate what your result might be?
Yeah, that's a really good question. Most of the time, patients have already had many rounds of Botox, and with time, it tends to not work as good as it did in the beginning, just because your body adapts to it. And so if they haven't had any Botox injections, I'll often work with our rehab physicians, do this, or sometimes neurologists as well, and say, listen, why don't we try focusing on these muscles and let's try the Botox and see if they like that effect. And if it was very beneficial, then that sort of mimics what we can do surgically as well.
Essentially, a little bit of a test drive.
Yeah, that's exactly right.
Yeah. How do you take into account what the patient and what the families want?
That's the largest driver of the treatment pathways that we're going to take. Some parents, again, have done all of the non-surgical things for so long, and they're just at the road's end there, and they want to try something a little bit more long-term and long-lasting. And so they're really going to be the ones that drive that. And if a parent brings a child in that they haven't tried any more non-surgical treatments first, then it's certainly good to encourage them to try some of the other less invasive things and get that maximized before we go create scars and have the risks of general anesthetics and so on. It's driven largely by us just informing the parents and the family and even primary care providers of here's all the options we have. And now we let them decide what they feel would be best for their child.
In some instances, it would seem that where there's a known injury, whether a one-time injury or a progressive injury, that part of the issue is when do you start to have the conversation? When do you want to have that first conversation about here are the options that are going to present themselves over the next months to years to decades?
Yeah, that's another good point, because there's often this waiting period where we're seeing what type of recovery they get neurologically after an injury, like a traumatic brain injury, for example. And then there's often this hope that many parents have, right? That maybe with time, that's going to get better on its own. Typically, we would want to wait a year after an accident to just see how things are settling out, focus on therapy. I can't emphasize how important occupational or physical therapy are in that type of setting, and just see where things settle out. And then it's saying, okay, this looks like this is what a permanent neurologic deficit is going to be. And then it's counseling with the parents, right? To let them know that in 2025, we don't have the ability to repair the brain or the spinal cord yet in an extremely meaningful way. But explaining to them that all the things that we do surgically, whether it's moving tendons or lengthening muscles or doing selective neurectomies, many of these things don't preclude some neurologic recovery in the future that might be meaningful to them as well. So it's just explaining that to them. Now, there are some things that are permanent that we can't undo. For example, in our last episode, I talked about fusing an older child's wrist. Like that's going to be a straight wrist that doesn't move permanently, right? That can't be reversed. But doing those procedures are more rare than just doing musculoskeletal and neuro procedures.
It is a fine balance, though, isn't it? Of finding the right timing. And the timing, I think, has both technical implications as well as personal and family implications, people working through trying to figure out what we can do. And let me just say that I think that some of the unsung heroes of almost everything we do are the occupational physical therapists.
Yes, absolutely.
I would guess that, and I think you've already made this point, but I'm just processing it, that the work with the occupational physical therapist is going to help elucidate both where the potential is going, but also help fine tune what you can offer and what expectations we can have.
Yeah, you're right there. I think therapists just have such a great way of putting function into context of anatomy and of structure. And so there might be things that they come up with that I wasn't even thinking about that might add significant function to a patient. And so I really rely on them preoperatively on getting their input and assessment to what we might be able to focus on surgically. And then also after surgery, right? They're going to help us maximize the results and the function after moving tendons around and retraining, a child to now one of their muscles that used to flex the wrist is now a wrist extensor, or muscle that used to flex the wrist now straightens their fingers. Those are things that take a lot of dedicated therapy and re-education to maximize the benefit of.
So give us some examples, and you've alluded, I think, to several of these procedures, of a few of these procedures, for one thing, how the procedures evolve, and then how do you match procedures to the goals and balance the expectations for what you can offer?
Okay, so again, it all depends on how severe the spasticity is. And so for patients with really severely tight spastic muscles, I think that doing the neurologic procedures, the nerve selective neurectomies alone are not going to be all that effective, right? Because the muscles by that point have permanently become shortened and fibrosed. And no matter what I do to the nerves, that length is not going to increase, right? So in that particular setting, I have to do musculoskeletal procedures as well as nerve procedures. I have to lengthen the permanently shortened fibrosed muscles. I sometimes have to transfer those tendons to repurpose their function to help create balance. And then again, my thought is, and what our research is showing is that if we can do the selective neurectomies in addition to those musculoskeletal procedures, then we get a better long-term lasting result. So that's what I think about for the more severe ones. Now, the more mild cases of spasticity, where there's not permanent shortening of a muscle, for example, I can still get full range of motion, right? Say, for example, the elbow, I can straighten it all the way to completely straight. In that case, then I don't have to do the musculoskeletal procedures. I can just do a selective neurectomy or a hyperselective neurectomy of the muscular cutaneous nerve. And that's going to be enough just to relax that muscle and allow them to have an easier range of motion, of the elbow. And then, of course, this is a spectrum. There are patients all in between that are more moderate in severity. And again, on some of those, we likely have to do some of the muscle and tendon procedures in addition.
Just to back up on that one a little bit. So what's the practical effect going to be for that patient who you've eased the process of extending the arm?
So the practical effect is going to be now they have a much smoother and easier range of motion of that joint. And for example, in some patients, it just takes so much concentration and effort to straighten their elbow all the way out. They can do it, but it takes time and it takes a conscious, dedicated effort. Once we relax those tight muscles, then what that does is it allows them to be smoother and quicker and more direct. So their triceps can kind of take over now and not be overpowered as much. And again, that leads to increases in coordination and overall function.
The little things we take for granted.
Yeah. And then, a lot of kids, when they're running, for example, or walking fastly, those arms pull up, right? And they have this kind of abnormal look when they're walking or running. And what it does, again, it just helps kind of relax that a little bit so that doesn't happen to the same degree. Now, of course, none of this is a cure for the neurologic insult that they had that caused the spasticity. It's just managing that spasticity and making it better, not perfect, but certainly, going for improvement of the posture, position, and function.
Sure. I mean, as we talked about last week, improvement in function, improvement in appearance, and sometimes just improvement in human dignity.
Yeah, those are so hard to measure too, right? Like we've tried to narrow down a lot of these tests so we can sort of see a functional difference before and after. But how do you measure the human dignity part and how you measure really even the appearance part is hard. You can do patient or parent satisfaction, but that's so subjective as well. But anyway, I think Many of my patients have just been so grateful that this has given them just a little bit more normalcy in their lives. And that's with all of those realms that I mentioned.
Sure. And goes back to what we were talking about before is exploring with the patient and with the patient's family, what can you offer? What are the realistic expectations? And those realistic expectations being both what are the limits, but also what does it free them up to be able to do?
Yeah, that's exactly right.
Yeah. Any other procedures that you'd want to put into context?
I think we've talked about most of them quite a bit. I sort of group the procedures that we do into musculoskeletal procedures and then the nerve procedures. And the musculoskeletal procedures, again, I mentioned some of them. I haven't mentioned all of them, but it's always some combination. And each one of these we individualize to the patient because they all have slightly different needs and problems for us to deal with. The most important thing that I should probably emphasize is that a selective neurectomy, there's a reason why it's called selective, because we go into one nerve that goes to one muscle or one set of muscles. And so it's really good for focal problems. Where it's not as good is when every single muscle of an extremity is spastic. Okay. For example, in spastic diplegia, both lower extremities globally have spastic muscles, flexors, extensors, and so on. And in that particular scenario, it's not as helpful because if I wanted to go into every single nerve, right, to every group of muscles, they would have incisions all over both their legs. And so that's not as practical of an indication for the selective neurectomy. In that particular case, some of our neurosurgery colleagues can do something that's similar, but up higher, more proximal, something called a selective dorsal rhizotomy, which is a lower back spine procedure where they can go in and actually affect the nerves all at once and not have to do all these separate incisions. And these more global spastic limbs, we got to think about other options as well, because working on the musculoskeletal system or just doing the peripheral nervous system is going to be too many incisions and approaches. So in those cases, we also think about, again, going back to more medical management, right? We think about baclofen or even to combine surgery and medicine, it would be something like an implanted baclofen pump. Again, our neurosurgery colleagues are great at implanting. When you have a global problem like that, and you have to have a global solution. So that's the limitation of some of the surgical procedures, right? Is it's better at these focal problems and not as good at global problems. But oftentimes I just ask the parents, what is the biggest issue that your child is having? And then we focus on the big issues. If it's the elbow tightness, that's the one we probably have the most experience with and the most outcomes data on, or the wrist that's flexed or, things like that. But when it's every single thing is tight, then we got to really maximize the medical management first and then consider more focal surgeries.
You touched on the notion of the nerve reassignment, moving the nerve to a different function. How commonly is that done, and how do you make that sort of decision?
Yeah, I think I talked a little bit about doing tendon transfers where we reassign a tendon's function, but you bring up
Oh, yes, you're
another
right.
innovative procedure though that is called a nerve transfer. And that's another new type of peripheral nerve procedure that over the past 10 to 15 years, we've really been refining. And we do that a lot, not as much for spasticity, although some people are starting to do this for spasticity as well, where again, we remove an overactive nerve from one area to an area that's maybe less overactive. But it's more commonly used in brachial plexus injuries and in other high nerve, peripheral nerve injuries, where we can actually reassign a nerve's function through a nerve transfer. Yeah, not quite as common for spasticity though there.
Thanks for clarifying that. And the tendon transfers, that's something that's done for a while. And again, I'm trying to explain this to myself. A lot of what we're doing when we do something like a selective neurectomy is correcting the balance by decreasing overload on the side that's not being opposed any. And so it's not really adding the muscle action that used to oppose it, but decreasing the muscle action on that side, which is a tremendous advantage for all the things that you're talking about. In moving a tendon, How do you make that decision?
Yeah, so that's a great question. So in that scenario where we are moving a tendon, it is adding a function to a weak function, right? So it's taking something that's tight and overactive and we're transferring it, repurposing its function altogether to be the counterbalance. And so we do this again. This was something that came out of Paul Brand's work with leprosy. And, Paul Brand was a missionary surgeon. I'm trying to remember, he was in the 1950s, 60s, and 70s. And his parents were missionaries in India, and that inspired him. So he went and basically dedicated most of his career to living among the lepers in India and innovating these procedures to restore their function. And leprosy is where bacteria obviously attacks the nerves, and so you get paralysis. And he noticed that if they were lacking their extension of their wrist, for example, or he could just take one of their normal functioning wrist flexors and he could move that back to a wrist extensor and get extension back. And so he really pioneered it. And so we use this now a lot for nerve injuries, and we use it for spasticity as well. And so again, it's just every one of these cases we look at and we say, okay, what's functioning well and what's not functioning well? And how can we balance this out a little better? The downside with moving a spastic muscle and a tendon that's associated with that muscle is then sometimes you make the opposite problem true. You go from having a flexed wrist all the time now to a really tight extended wrist all the time. And so that's been the long-term problem with using tendon transfers for cerebral palsy is sometimes you get undercorrection, but even more common, you get overcorrection of a problem. And that's where now in 2025, we can just do a selective neurectomy to that muscle that we did the tendon transfer on. So now we're weakening the muscle a little bit, making it have a little bit more normal muscle tone and repurposing it both together. So that's kind of where we are in this day and age is we can use a combination of these approaches. And again, the goal is getting better outcomes. And that's something we've been studying and trying to get it out there in the literature for people to know.
The thing that really seems to stand out to me about all of this is that while there are a lot of very common principles, that the advantage and the beauty of this really comes in recognizing that not one size fits all, and that by working in a team approach, including therapists who have known them for a long time, family who deals with the issues all the time, pediatricians who have been able to explore stuff with families, that you just have a lot more options these days to be able to try to give each patient the best individualized result you can.
Yeah, we really do. And I'm thinking back to our last podcast, and I failed to mention as part of that team, the physical medicine and rehabilitation
Oh, man.
doctors who
Yeah.
are such a critical part of all this. And some of my favorite colleagues, right, that I get to work with. And so, boy, having everybody with their own specialties contribute makes us all better and makes the outcomes for patients so much better. And so I really can't emphasize enough that any one of our subspecialties alone is really almost helpless without working together as a multidisciplinary team.
Right. And I think it really entails both recognizing what everyone can do, which involves a lot of talking to each other, I think, and just the collaboration piece of batting things around and trying to come up with the best solution. I just wanted to touch in passing. So, speaking of medical missions, you're just back again from another medical mission to Ukraine. I'm guessing that you were able to do a lot of good, but without as much luxury of time and refinement of your plan.
Yes, I think that's a good way to put it. There's this tremendous need in Ukraine, even before the war. There's just not surgical subspecialization or medical subspecialization to the same level that we have here in the United States and Ukraine. And they have a decent medical system and they have some incredible practitioners, but they just don't have the training that we have here. And so what that means is there's a lot of populations of children and adults, but children in particular that go untreated, right? And that sort of are almost abandoned. And so when we go there, I've teamed up with this nonprofit organization that provides free surgical care for children of Ukraine, and it ranges from anything from cleft lip and palate and other facial or ear deformities to what I do with hand and extremity reconstructive surgery. And so what we do is we go there, and typically we spend 2 weeks at a time. We spend 1 week at Children's Hospital there, and then another week at a separate children's hospital that we partnered with. And we bring as many supplies and equipment as we can. And then they have, surgeons from the whole country come in and join us to learn. And what we do is we send out announcements on social media to have children with all these different conditions, including cerebral palsy and spastic conditions, come and see us. And we spend a half a day just screening patients. And this last time I was there, we ended up seeing, I think, somewhere upwards of 150 children. And then we select as many as the time will permit. So then we operate for 4 to 5 days straight on these children. And so we ended up doing about 75 operations total in 2 weeks.
Wow.
And what we do is we see these patients all as a team, and we say, okay, here's the biggest problems, and let's prioritize these ones. And then we do these operations on these children and teach as we're doing this, right? So the local surgeons, now next time they see that particular pathology, they can take care of themselves with a little more confidence. And then again, we got to work with some of the therapists there as well. And it's just an incredible opportunity, because many of these parents have just been hoping and praying that they would find treatment for their child at some point in their lives. And so, especially during the wartime, they're even more grateful, right? Because there's even less resources available. And about half of the children I operated on, their fathers were away at war. So very humbling experience. But these people just have a heart of gold, and they're some of the most grateful and generous people I've ever met. And it was such an honor for me to be part of this organization and to have the support of the University of Primary Children's to let me go do this for a couple of weeks at a time.
What a tremendous effort. Thanks for doing that. And thanks for letting us know about that. So next week, we'll talk a little bit more about the future. I think we'll prognosticate a little bit about what future for individual patients, but also where you foresee the future of what you do going. Thanks for being with us.
That sounds great. I think the future is bright, just like we innovated over the last 30 years. I think the next 30 years are going to have even better treatment. So look forward to it.
I look forward to talking. Send your questions to questions@vcurb.com. Shawn Mendenhall, thanks for spending some time with us today, and we'll talk to you next week.
Thanks so much, Paul.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who also composed the theme music. See you next time.